Good afternoon. My research is all about the efficacy of ultrasound-guided bilateral transversus abdominal plain block and decreasing pain after laparoscopic cystectomy. It has been well established that laparoscopic cystectomy is the gold standard for gallbladder stone surgery. However, its post-operative pain is complex in nature and consists of three components: the visceral, somatic, and the referred shoulder tip pain. If pain is poorly controlled, it may result to chronic pain syndrome and increased morbidity and mortality. Thus, effective analgesia should be multimodal with the least potential side effects, which connotes an opioid-sparing analgesia regimen. Due to this concern, there is growing interest in top block and the surgery, which claim to address the issues mentioned earlier. It is an abdominal filled block that has been introduced for almost 20 years, in which a relatively large local anesthetic solution is infiltrated between the internal oblique and the transversus abdominis muscle to produce sensory block over the anterior abdominal wall from T7 to L1. To date, more than 20 original studies have addressed this technique in laparoscopic cystectomy. However, there are still contradictory results and controversies in reduction of pain score, which is said to be minimally relevant in this population. So the objective of this study is to compare the post-operative pain score using the VAS scores of patients who received the top block versus those who received the placebo using the visual analog scale, so at rest and with movement, at the first, second, 4th, 12th, and 24th hour of post-operative period. We also would like to compare the rescue analgesic demands using the tramadol IV. And lastly, I would like to evaluate the overall satisfaction of patient and acute pain management. So this research would use a prospective randomized double-blinded clinical study. So after approval by the local institutional ethical review board, written informed consent was obtained from all participants. In total, 46 patients were prospectively enrolled with the ASA score of 1, 2, and 3 at the age range of 21 to 65 years of age. So these 46 patients were randomized using a sealed envelope, and patients, the anesthesiologist, the operator, and the staff assessing the post-operative pain were blinded to the group assignments. A total of 4 patients were dropped out in the study, in which 2 had a shift of surgical technique to open, and the other 2 had mild hypersensitivity to ketorolac, and the other one was to latex. After the surgery, the patient received his or her intervention according to group assignments. The top block group received a 20 ml of 0.25% bupivacaine, and the control group received a 20 ml 0.9 NaCl, and both were given bilaterally. Then pain was assessed using the VAS scores at rest and upon movement. So they were recorded as so with the total tramadol IV rescue demands for the first 24 hours post-operatively. On the 24th hour, patient was asked of their satisfaction level on the acute pain management using a 6-point Likert scale. The sensitivity analysis for assessing if the dropout rate was significant showed that the best case and the worst case scenario assumptions showed the same results. Thus, the study conclusion did not change with the assumptions made. For the statistical analysis, we've used the independent t-test for the quantitative continuous variables, the Wilcoxon-Mann-Whitney test, the chi-square test, and Fisher-Exact test. And a p-value of less than 0.05 was used as a cutoff for significance. Baseline comparability studies showed no significant differences between the two groups in their demographic and clinical characteristics. This slide illustrates the differences in post-operative VAS scores at rest between groups. There was a decreasing trend in VAS scores at rest for both groups, with a noticeable drop on the 8-hour by as much as 50 to 56%. Scores were noted to be higher in the control group from the 1st to the 8-hour and almost equal by the 12-hour. The differences, though, did not reach statistical significance. However, the mean VAS score of patient in the control group in the 2nd-hour interval was significantly higher. Likewise, a decreasing trend in VAS scores and movement for both groups is depicted in this graph, which was more pronounced in the 8-hour. Scores were noted to be higher in the control group than in the top block group and were significantly different from each other in the 1st to the 4th hour post-operatively. The succeeding time periods, though, no longer showed significant differences in scores. This table shows the 71% and the control group demanded rescue analgesic at least once. Conversely, 52% in the top block group did not require rescue analgesics. However, there was no significant difference in the requirement for rescue analgesia between the two groups. For the satisfaction rating, there was no difference between the two groups. Both groups were equally mostly satisfied with the relief from pain after 24 hours post-operatively. Previous trials by Edo, Lotley, Ra, and Peterson, and meta-analysis studies regarding top block and laparoscopic cholecystectomy have demonstrated analgesic efficacy of top block after laparoscopic cholecystectomy. This gives credence to our findings of lower VAS scores at all times. So a similar finding by Peterson et al. Reported significant reduced VAS pain score while coughing in patients who received top block versus placebo group, while no significant difference between groups in VAS scores at rest. Most demands of tramadol was at 0 to second hour, which coincide with the study of Peterson et al., who reported reduction of morphine consumption at 0 to second hour post-operatively. However, the actual reduction in morphine was not significant, as so with our study. Significant reduction of pain score and rescue analgesia could have been achieved if both the somatic and the visceral component of pain are addressed by top block, like the quadratus lumborum block, which provides both the somatic and the visceral analgesia. Furthermore, supraumbilical analgesia could have not been achieved for the upper port incision of the lateral approach of the top block, which was performed in this study. So despite the moderate pain levels reported by patients in both groups, all claimed to be mostly satisfied, which implied that their expectations on pain management were met. Cultural and religion influence might have played a great role in their expectations on their pain experience, since Filipinos are known to be stoic in the face of pain. Top block is an acceptable and safe choice for postoperative analgesia. It improved postoperative analgesia in patients receiving laparoscopic cholecystectomy, especially during movement in the acute postoperative hours. Further investigation is needed to fully explore the benefits of top block as the sole pain control, or at the least an adjunct to a parenteral or oral multimodal pain control regimen in laparoscopic cholecystectomy. Thank you.
Nasa ano na tayo siguro, no? We are already in the stage of ultrasound-guided peripheral nerve blocks. And I want to congratulate you for having that kind of expertise and skill in performing your top block on your laparoscopic cholecystectomy. But I have a problem. Would you have not done that top block prior to your induction of your general endotracheal anesthesia? I made also a research on this, and all the procedures were done prior to the induction of your general endotracheal anesthesia.
That was one of my consideration prior to this study, but we opted to do it after the surgery so that we won't delay the start of the surgery, because we also want to ask the consent.
You have to inform your surgeon that you are making a research, and we need their cooperation also. So it should have been done prior to your induction.
Yes, noted.
In corollary to Dr. Rielubit's question, do you think it's safe performing the block while the patient is under general anesthesia?
Yes, ma'am. Since it's ultrasound guided.
Okay. What about the onset of the block? Because my concern is the results of your paper show that there's no significant difference. Do you think it was because of what you did? You did the block before extubation.
Yeah, it could be, ma'am, a factor since the onset. It would usually peak at the 80 minutes, usually after an hour. So it is a consideration in this study.
So as a suggestion, before you make a paper, you have to take into consideration these things. Okay, so the last one is there is no paucity. I mean, there are a lot of studies using tap block in laparoscopic techniques,